Hey everyone, it's great to be back with you. My name is Brandon Johns, and I am a paramedic and a registered nurse. And today we are going to talk about pre-hospital heparin administration, particularly for the STEMI patient. This is for the North Carolina EMS Instructor Methodology course. In the introduction here, you also see that I put that I'm an MSN FNP, Family Nurse Practitioner student. I am pursuing my nurse practitioner in family and emergency medicine. So I say that to say this, that you all are getting a sneak peek of my capstone project for my program. So hopefully within the next couple of years, this will maybe be rolled out into a county near you as protocol. I would love for the day that this is something statewide or nationwide or whatever we can, however we can get that out to the patient for better patient outcomes. That is ultimately my goal. So again, we're talking about pre-hospital heparin administration and for the STEMI patient in this scenario. So first, this disclaimer, I'm going to read it for you. I think it's important word for word. So this information in this presentation is for the purpose of this course alone. This information does not provide any continuing education credit, nor should it be used in the clinical setting. All medical procedures and medications, they require approval by your local and state authorities. This is in no way permission to practice, so please refer to your scope of practice and clinical guidelines. So our objectives here today. Cognitive objective here is understanding the rationale and safe administration of pre-hospital heparin. The psychomotor is to demonstrate an accurate heparin preparation and administration of the medication. And most importantly, the affective objective is to appreciate and understand that the EMS role in improving STEMI outcomes. I think the EMS provider is the person who can make the most beneficial outcome in recognizing STEMIs and getting them to the appropriate facility. And I believe the paramedic in the truck, in the field, can have some of the best impact on outcomes. So why does this even matter? You know, we all know that STEMIs, they are time sensitive. We always think about the door to balloon time and how can we reduce that time? How do we speed up the process to get the patient into the cath lab and on the table and get that first balloon inflated so that we can get blood flow beyond that lesion? EMS plays a major role in early reperfusion, and we do that through robust STEMI protocols that we have here in North Carolina and throughout the country. I believe there is a gap in pre-hospital anticoagulation protocols. Paramedics across the country, we all know 324 of aspirin and high flow diesel. I believe there is a gap there, and I believe more can be done by the paramedic, and the paramedic has that training and experience, and I believe the paramedic is the exact person and they are in the perfect position to improve these outcomes. So first, before we get into heparin administration, we'll talk briefly here about the pathophysiology of a STEMI. What is a STEMI? You know, a lot of patients, just like EMS, 90 to 95% of your calls and 90, 95% of our cases in the cath lab are routine. They don't, the patient comes in, outpatient scheduled, cardiac cath, they saw something on a CTA or they saw something on a stress test. So now they want to get the patient cathed. We bring them in, we cath them. So some of what we see in the cath lab are mainly stable plaque. In that top left picture there, that is a stable plaque that grows over time, and it's a chronic issue. There's a low risk of it rupturing. Anything can happen, but this is a lot of what we see. What you all are dealing with in your STEMI patients is something a little different. And what that is your unstable plaque. So this plaque, there is a rupture of a plaque, and that leads to a thrombus formation. That thrombus formation, platelets go to that site and they start trying to repair that site, and they build up and build up and build up, and that leads to a total occlusion of that artery, and blood flow cannot get to the myocardium beyond that rupture. So this is an occlusion of the coronary artery, and like I said, beyond that occlusion is ischemia, and myocardial death can occur. So that's why it's very time sensitive. Some of the other lesions you see there are calcified lesions. Those are chronic lesions, and these build up over time. Some of these patients, they may have been cathed a couple of years ago and they had a 40 or 50% lesion, and now it may be a 70 or 80, and now it's time to put a stent in. These aren't acute situations. Sometimes they even have what we call CTOs, or chronic total occlusion. That vessel has occluded and been occluded for months or even years, and the body has built pathways around that, and that's something we see, and that's nothing that we're sometimes there's situations where we can't do anything with those chronic total occlusions, and these calcified lesions. Those are hard to get out of the way. But what we're dealing with in a STEMI are those unstable plaques there you see in the middle, and on that bottom in the middle, the thrombotic lesions, those as well. And even vulnerable plaque, that's something that can rupture, become unstable, that thrombosis occurs, and then we see them in the cath lab from the back of the ambulance. So let's talk a little bit about the extrinsic versus intrinsic pathway. We're not going to go into too detail of the clotting cascade, but we do need to cover it just a little bit. So extrinsic is what we're seeing when we see a plaque rupture, and that rupture occurs, the extrinsic pathway takes off because of collagen and inflammation, and that thrombosis occurs, okay? And then intrinsic pathway amplifies and sustains that clot formation. Heparin is going to target that intrinsic pathway, not the extrinsic. So the rupture has occurred, the clot is starting to form, and then the intrinsic pathway takes over, and then it leads down to a common pathway. Heparin's going to help stop the buildup through the intrinsic pathway of that clot. And then ultimately, heparin can help neutralize thrombin, and that prevents the conversion of fibrinogen to fibrin. So when you hear the word fibrin, I want you to think of when you start an IV on someone, and you start that IV and then you flush it and it draws back very nicely, and you flush it and clear out your line. You get them to the hospital, and the ER staff, they go to take a blood sample from that. Some of your agencies, some of you all out there may go ahead and get the blood you need in the back of the ambulance. And there's a good reason for that. It helps speed things up, but also because of fibrin. On the end of that IV catheter that's inside the patient, it's a foreign body, and the body starts to build fibrin. Fibrinogen turns into fibrin and builds fibrin on the end of that IV catheter. So sometimes you can flush it fine, but you can't draw blood back off of it. And that is because of little fibrin clots that get on the end. Sometimes you can force flush it and break up that fibrin clot, but it can be difficult. And then you have to do a straight stick or start another IV to get blood. And that's the reason why. So when we give heparin in the field, what exactly are we interrupting? That is what we're interrupting in the clotting cascade. That's the intrinsic pathway. So why are we talking about this? Why don't we just give aspirin and leave it at that and get them to the hospital? You may be shocked to hear that there's several studies out there, they show that anywhere between 5 and 40% of the population that we take care of are non-responders to aspirin. 5 to 40, that's a big number, so we'll stick with 25. 25% of the people that you give aspirin to are non-responders. 1 in every 4 you may not be doing anything for. In the cath lab, we do something called DAPT, or dual antiplatelet therapy. This includes aspirin, so we always need to know, did EMS give aspirin? And then after, sometimes before, depending on where you are and what the cardiologist likes, sometimes before the case, sometimes in the middle of the case, and sometimes at the end of the case, once we place the stent, they will get a P2Y12 inhibitor. So these are medications like Plavix, Effient, Brilinta. We give these medications to help with the aspirin and to keep clots from forming inside the stent. A stent is a foreign body in that coronary artery, and when we put that in someone, the body's reaction, natural reaction, is to not like it and want to clot around that. So we have to put somebody on a P2Y12, and that usually stays for about a year. They'll be on that for about a year. Plavix is honestly our workhorse. It is one of the cheaper medications. It's reliable and it's available, right? So our patients can get it. It's cheaper. And I know we think about, well, it doesn't matter how much it costs the patient, but really it does, because we need it to be cheap for them so that they are compliant. And I tell patients this, as soon as I give it to them, this is your Plavix. You have to take it now, and you have to take it every day. I want you to set an alarm on your phone and take it the same time every day. Don't miss a dose. If you miss a dose, your stent could clot. And if that stent clots, you may not make it back to the hospital. And I make sure that they're very aware of that. So we make sure they have their aspirin from EMS, and then we also give their P2Y12 inhibitor. It's been proven, like I said, Plavix has been proven in long-term trials. In the COMET trial, the CURE trial, these show that Plavix works, and we use it today, even though it is one of the older of the 3 that I mentioned. And like we talked about already, heparin, it really does complement the targeting that thrombin pathway to prevent that fibrinogen to turn into fibrin clots. So the mechanism of action, how does it work? We've kind of covered that, but in low doses, it prevents conversion of prothrombin to thrombin by some of its effects on factor 10A. In higher doses we talked about earlier, it neutralizes thrombin. It prevents conversion of fibrinogen into fibrin. Ultimately, we're preventing thrombus formation, and that's usually a subtherapeutic dose or a lower dose like we're going to talk about that could be given by EMS. And some higher doses or full therapeutic doses, it's preventing the extension of existing thrombin. So we will talk about those doses. Heparin, and when you give it, it does have a rapid onset. It takes about 5 to 10 minutes to get to peak, but the onset is rapid, and that's what makes it so nice. So how do we monitor how much heparin to give? How much do we know to give? Well, that's pretty easy in the cath lab. We monitor a little different in the cath lab than how it's monitored in the ICU. We use something called ACTs, or activated clotting time. And if you look in the picture here, you see a picture of an iStat. That is an iStat machine. We use that machine. It looks just like that. We use a cartridge, an ACT cartridge. That cartridge uses kaolin, which is a silica, and it simulates cell surfaces, which activate the intrinsic coagulation cascade like we talked about earlier. So this kaolin, or it's a clay mineral inside that cartridge, it mixes with the blood and it gives us a number in seconds. So our goal during a PCI, we want to be somewhere around 250 seconds. That's where we like to be. We know most patients in the ER, when they come in by EMS, they get a bolus dose of heparin. Some get placed on a drip, but they typically get a bolus dose. It's usually between 4,000 and 5,000. We like it closer to 5,000. When we start a case, if heparin hasn't been given, we're typically going to give 5,000 of heparin. So once the heparin is given, we can wait 5 to 10 minutes for that heparin to reach its peak, and then we can run an ACT. And we're looking for an ACT, like I said, around 250 is where we like it to stay. We can look at a number, say if we get a number back, say it's 230, well, we want it to go to 250. We know we can give about 2,000 units of heparin there, and that would get us somewhere around the 250 mark. So we like to say for every 10 seconds, 1,000 units of heparin. May not be exact, but that's kind of what we go off of and how we measure how much more heparin we're going to give. So for this course, I did write a EMS protocol, and I will show it here on the screen. But this protocol snapshot would be for the adult STEMI patient with confirmed ECG. Obviously, this has to be a standing order or medical control. The patient would have to have ST segment elevation, just like you would call a STEMI. So the goal here would be to activate the STEMI alert, ensure that the cath lab is activated, you have a cardiologist who's en route, and your standing order would be to give typically a weight-based dose of heparin. We will talk about that in another slide about how much. But the goal here, the key here, is to make sure that the cath lab would be activated and that the patient would be en route with a cardiologist on board. We have to have that cardiologist. And there's still some agencies out there that do fibrinolytic therapy. That's in very rural medicine, probably out west. And if you're in Montana and you have a flight where it's going to be 2, 3, 4 hours before you get to definitive care. Some of those agencies out there still use fibrinolytic therapy. We don't see that a lot around here, thank goodness. We can get people typically to cath labs within an hour around in most parts of North Carolina. So when would we not give heparin? So some of our contraindications, obviously if they were actively bleeding or if they've had a recent surgery, we typically say for recent, how do we define recent? Typically we say 4 weeks or 1 month to 3 months. That's a strong contraindication to heparin therapy. So that would be something to ask. Have you had a surgery recently, or you see a scar of some sort, or you're picking them up from a rehab facility? Did you just have surgery? That's a good question to ask to make sure that they haven't had one lately. If they have a history of hemorrhagic stroke, same thing there. A month to 3 months, we don't want to. That would be a strong contraindication. I would say less than a month would be an absolute contraindication to heparin therapy. Also, if they have a known history of HIT, if this patient has HIT, heparin-induced thrombocytopenia, we wouldn't want to give them heparin. If they have an allergy or a religious restriction, it's important to know where heparin comes from. Heparin is dosed in units, and typically medications that are dosed in units come from natural sources. So heparin comes from pig intestines. So we would ask them, are you allergic to pork? Or do you have a religious restriction to pork? Particularly that, so in some Jewish faiths and Muslim, they don't consume pork, take in anything kind of pork product. So we have to respect that. If I get somebody on the table, I had somebody the other day, he was Muslim. I could, just talking to him, I asked him, hey, do you consume pork products? He said, no, I never have. So I explained to him, I said, this medication that we use in the cath lab contains pork, or it comes from pork, from the intestine of a pig. Are you okay with that? And he said, well, I've never had that. And I said, okay, well, we have other medications. Typically in those situations, we use a medication called Angiomax, and we can use that to wipe our wires and flush our lines. And we can also give a bolus dose of Angiomax in those situations. And also uncontrolled hypertension. Anytime somebody's, if they're hypertensive, 220, 240 systolic, we don't want to give medications that can thin them out because they're at high risk for stroke. And if you heparinize somebody and then they have a hemorrhagic stroke because of hypertension, that's not a good day. So we would avoid that. Heparin dosing, how do we dose it? 60 units per kilogram is our IV bolus typically. Some people like 50, some 40, but usually 60 units per kilogram IV would be your bolus dose. And then a max dose on that initial would be around, but like I said, between 4,000 to 5,000 units. I like 5,000 better. And if I was Dr. Medical Director, I would write a max dose of 5,000, but I'm not. Concentration, how is it concentrated? If you look at this picture, you will see vials of all different colors and shapes and sizes. Typically in the cath lab, we carry a 10,000 unit per 10 ml, and that makes it very easy for us because we give large aliquots of heparin. So we'll give, some cases we'll give 15,000, 20,000 units of heparin, sometimes more. It just depends on how long we're in the case. So this is something that would have to be very careful in EMS and make sure that everybody in the agency knows what we carry, the concentration that we carry, and how we're going to use it. A good, if 10,000 and 10 mLs didn't work, 5,000 in 1 ml would be a good alternative. But like I said, there's a lot out there. So that's something that would have to be discussed in depth to say, hey, this is what we're going to carry, and don't pick up a random vial of heparin from your ER visit drop off and put it back in your bag. That would be too unsafe, and we wouldn't do that in the hospital, in the cath lab, and I don't think EMS would do that either. But crazier things have happened. Also, just look here. I want to give, when we talk about 60 units and a max dose of 4 to 5,000, say if the max dose is 5,000, just an example patient here. So say if there's a 73 kilogram patient and we're using 60 units per kilogram, that comes out to 4,380 units. Just give 4,400 units. That's how that would be dosed. There's no way to draw up in a syringe, in a vial, 4,380 units. Nobody's getting that close, that specific. In those cases, I would just give 4,400 units and call it a day. But like I said, that would be addressed later in training. Administration and documentation, pretty just like any other medications we give. We have to make sure we give the correct dose over the correct time, and then document that. So write time, route, dose, response. These are all important parts of any medication, not just heparin. Administering heparin, do you have to give it over 1 to 2 minutes? Not necessarily. Sometimes there's a lot going on in the cath lab and it gets in the patient quick because I've got to move on to the next thing, or the camera and the C-arm is getting ready to knock me out and I've got to get out of the way, and I don't want to get my head radiated from being right there at the IV site giving medication. If you didn't know, when you take your STEMI in, the doctors typically want to access the right radial site or right femoral site, depending on what our anatomy looks like. So we like an IV on the left arm. I'm going to be working from the left side of the patient. So having that left arm IV in a STEMI patient is very nice and very helpful for me. So just so you know, thank you. So anytime we give a medication that has a reversal agent, I think it's important that we know about it. Protamine wouldn't be something that I would foresee being placed into an EMS protocol. It's not something that would be given just for 4,000 or 5,000 units. Protamine's given. It is the reversal agent for heparin. It binds to the heparin, therefore making it inactive. And it's not something that you would give, like I said, for 5,000 units of heparin. This is when we give people 20, 30,000 units, and typically in other cases we don't normally use protamine to reverse heparin in cardiac cases, but it is important to know that protamine does exist, and that is how you reverse heparin. There is a dosing, 1 milligram per 100 units given. Typically a max dose is 50, but just the other day I had somebody who would not stop bleeding and we ended up giving 80. So yes, do you go over 50? Sometimes you do, but it just is case dependent. This is very important. I know we talked about heparin going fast, and do you really wait 1 to 2 minutes and push it over that? Not always. I cannot say this with enough caution. Protamine, it has to be given slow over typically 10 minutes. I do pay attention to this. Protamine can cause a histamine release, and that will cause somebody to be bradycardic. We'll talk about that in the next slide. But what I typically do is take my dose, whatever I'm going to give, 30 milligrams or 40 milligrams or 50 milligrams of protamine. I put it in a 50 cc bag and I put it on a slow drip so I can keep working and doing other things in the room while we're finishing up a case. But I'd never slam protamine. Don't do it. So like we talked about, protamine, it can cause hypotension. It can cause bradycardia. I have not had it happen, but I have heard of it causing patients to go into cardiac arrest. It if given too fast. It does cause a histamine release and complement activation, and this causes vasodilatation, and it leads to hypotension. We do not want to do that. I think it's very important. If you were ever in a situation to give protamine, just give it slow, very slow. Sometimes when we give protamine, we do another ACT to see if it was effective and see if our clotting time has come down. Also to the right here, this goes beyond the scope of this video, but I love this stuff, so I'm going to talk about it for just a second. The TEG, or the thromboelastogram. This shows us how the function of the platelet and fibrin formation and clot breakdown. It's really cool. We use it. It can be used a lot in trauma cases, in trauma resuscitation, in cardiothoracic surgery, and in liver transplants. And these are patients who have bleeding disorders, and we want to know the lifespan of clotting and clot breakdown. And we can do that with this thromboelastogram. It is a lab test. You send the blood off to the lab, and there's a special machine. Not every hospital has them. Usually your trauma centers or any center that does cardiothoracic surgery, they will have a thromboelastogram machine. And it tells us a lot about what's going on with, like I said, coagulation and clot breakdown. Along with the protocol, I did do a pharmacology sheet in that protocol, and this is just a quick reference. So what is heparin? It is an anticoagulant. The therapeutic class is an anticoagulant. The pharmacological class is an antithrombotic. So like we talked about earlier, the onset is immediate. It peaks in 5 to 10 minutes. So that's when we wait to do the ACT, the activated clotting time, 5 to 10 minutes. We'll run one, see if we need to give more. Heparin usually lasts about 2 to 6 hours. So in these cases, so say if this was in protocol for EMS and they gave 5,000 of heparin, and then we get to the hospital and we determine, well, this patient's not a candidate for PCI. We're not going to take them to the cath lab. Oh no, they already got 5,000 units of heparin. What are we going to do? We're going to wait. It'll go away. A couple hours, 2 to 6 hours, heparin will start working itself out. The body will get rid of it. So usually in the lymph system is how heparin is moved through the body to get out of the body. So the body will take care of it. We don't have to rush and give protamine in those cases. Okay. Some of the side effects, what we already talked about of heparin, is bleeding, thrombocytopenia, and HIT, heparin-induced thrombocytopenia. Those are bad cases, and those HIT, you see that some in the ICU. You don't usually see it acute. It's chronic when patients are on heparin drips. They start bleeding, and we can't figure out what's going on, and then they may start clotting weird, and we have to do a HIT panel and stop their heparin right away. That's when you get the tags, the thromboelastograms, see what's going on, see if you need to give FFP, if you have to give cryoprecipitate, get a fibrinogen level. Those are all ways that we deal with HIT. And then we just have to mark their chart for, usually under the allergy, we'll put heparin, and in the comments we'll make it that it's a HIT issue. So our psychomotor skill practice, just like anything else, when you learn something in EMS, there's a skill that goes along with it. So this time it would be a great time to pull out the equipment and pull out the vials and see get hands on the different vials and see what the different ones look like. Is this a 10 ml vial of 10,000 units or a 1 ml vial of 5,000 units? What kind of concentrations are we looking at? So we need to be able to verify and identify those concentrations. Using the correct syringe is important. If you're going to carry 10,000 units in 10 mLs, but you're only ever going to give 5,000 units max, maybe it's important that we have pre-labeled syringes that say heparin that are 5 ml, so we can't go over 5,000 units. We typically in the cath lab we have a 3 ml, a 5 ml, and 10 ml syringes. We go between them, but use a 5 ml syringe, put that in the protocol, have them, you can special order them or order labels or carry labels and open that 5 ml syringe, label that as heparin, and that way, even if the patient, their 60 units per kg dose was 4,000 or 3,500, you can only draw up 5,000, so you can only mess up a certain amount before you have to stop because you run out in that 5,000. Okay, so we talked about the calculated dose, 60 units per kg, and drawing up and label our syringes. That'll be an important part of the psychomotor skill practice. An error prevention scenario, we would definitely do that as part of psychomotor. So identifying the wrong syringe or the wrong label, wrong concentration. And anytime something goes wrong, we don't want it to be punitive. We want to figure out how can we correct it. Why did something go wrong? If one human can make a human error, any human can make a human error. So it's important to figure out what went wrong and how can we correct it so that it doesn't happen again. It doesn't have to be punitive in nature. So we're going to do a case study example here. You get called out to a patient, to a residence, to a 70-year-old gentleman. You get there and he's complaining of sudden chest pain, left arm pain, jaw pain, shortness of breath, all the things that say this is probably a STEMI. This is a cardiac event. So what do? We get our set of vitals. We get them on, first thing we do is get them on the 12 lead right away. Get our 12 lead, look at it. Does he have ST elevation? It's important to note, and I think you all know this, and I'd just like to reiterate it, that 12 leads can change just like that, instantly. So get your 12 lead, but always repeat your 12 lead. If they have an old 12 lead, use that to compare it to. I tell patients all the time, take a picture of this EKG before you go home. That way, if you ever have to call 911, they'll have one to look at. So, moving on with this 70-year-old gentleman, Mr. Jones, he called out, his chest is hurting, his arm is hurting, he's been short of breath. We get this 12 lead. Yep, it's a STEMI. So we transmit it, we radio in, we call, we activate the cath lab. We activate the STEMI alert. The ER doctor gets your 12 lead and he said, yep, that's a STEMI. I'm activating the cath lab. STEMI team gets activated, get your patient loaded up. We are now going to start moving that patient to the ambulance and get them transported, right? So first thing we're going to do is give our aspirin, 324 of aspirin. If they haven't taken it already, make sure we ask them. If they haven't, give it. And then we're going to work on, for our protocol, since our county, we're the first one in the state to get this protocol, we're going to use this protocol. We're going to give heparin. So we're going to give 60 units per kilogram of heparin, and this patient weighs 165 kilograms or 165 pounds. So we want to take 165 and divide that by 2.2, which gives us 75 kilograms. So we're going to take 60 and multiply it by that 75. How much heparin are we going to give? 60 times 75, 4,500. 4,500 units of heparin. Our agency, we're going to carry 10,000 units in 10 mLs. That's what we have. We have pre-labeled heparin syringes that are 5 ml. So we're going to draw up 4.5 mLs of that heparin. We're going to make sure this patient, what are our contraindications? This patient hasn't had a recent surgery in less than a month, and they haven't had, you got it, a stroke, a bleed, a brain bleed in the past 1 to 3 months. They met the criteria. They don't have an allergy. They don't have HIT. They've never had HIT. And they're not allergic to pork products. I think we can probably give this patient 4,500 units of heparin. The cath lab's been activated. Everybody knows we're coming in. What did I tell you at the beginning with aspirin? 25% of the population are non-responders. We can give this patient aspirin, and we gave it to him already, but we don't know if we're doing much with it. We're taking our chances, but we know this heparin's gonna work. So we can give 5,000 units of heparin, and we can stop some of that thrombus formation from that plaque rupture. So we've discussed it. We've talked about the risk. I think it's time we give it. 4.5 cc's, 4.5 mLs, which is 4,500 units in your IV. Monitor the patient, continue to transport, document your time, and when you get to the hospital, they may not be as familiar with our new protocol, so we need to make sure we communicate that. We gave the patient 324 of aspirin. We gave them 4,500 unit bolus of their heparin. This will be very helpful for the ER staff, so that they know what's been given, so they don't have to give it again. So let's go over what we've talked about tonight. That is not just STEMI recognition, but also understanding anticoagulation and how the two of them together, recognizing a STEMI and anticoagulation, how they can come together and improve outcomes. You know, when you bring a patient into the ER, before that patient can get 5,000 units of heparin from that ER nurse, they have to be registered. They have to get a wristband. They have to get a room assigned. The doctor has to see them. An order has to be placed in. It has to be verified by pharmacy. The medication has to be pulled from the Pyxis. It has to be drawn up and dosed and scanned and then given to the patient. All those things have to happen before that medication can be given to the patient. Well, with our new protocol we just got, we're getting ready to start. After you all have received this training, we can now save a lot of time and hopefully a lot of myocardium by filling this gap in pre-hospital STEMI care. I think it's very important. I believe EMS and paramedics are highly trained, highly professional people who can safely and effectively administer heparin. I cannot believe it's gone this long and hasn't happened yet, but I believe it can, and I believe it can happen safely. And I hope, like I said, over the next couple of years, through more research that I've got to do, and through more education, and through this program that I'm going through for my nurse practitioner, I hope that this is something that North Carolina one day will start to implement. If you have any questions, please feel free to send them to me directly. I would love to talk to people about this. I would love to talk to your training and educators at your agencies. I will talk to medical directors. I will talk to anybody about this topic that wants to listen, and hopefully this is something that can become more popular in the state. Like I said, if you have any questions, feel free to reach out to me. I'd love to talk to you more about it. And I believe in the work you do out there. You do important work, and every day you're really making a difference. And I believe this can just take that one step further. I'll end here with some of the references. American Heart is a great reference for STEMI guidelines. There's a lot of peer-reviewed journals out there on heparin and protamine and aspirin resistance. Like I said, I gave you the numbers. It's out there. North Carolina EMS, they do have some robust protocols. I believe that one day this can be something that would be statewide. Thank you all for your time. I appreciate it. Don't hesitate to reach out. I would love to talk to anybody about this that wants to listen. And you all have a great night.